We have put together this series of videos to help you know how, what, and when to document. So it's important to understand that there's a difference between assessment and documentation. Assessment is something that we're doing all the time. ICU nurses are assessing their patient constantly. It would not really make sense, nor would it be feasible in any kind of way, to expect anybody to continue to document every time they did an assessment. The objective here is to outline what is mandatory documentation for initial assessments and also for reassessment, and as well the expected documentation of things that we do for our patients. For example, dressing changes, line changes, and any care that is rendered to the patient needs to be documented. Additionally, any events or changes in patient status or condition need to be documented. This is probably the most frequently missed and most important documentation that we do. So we will try to cover every section of power chart documentation, keeping in mind that if something does not pertain to your patient, you do not need to document on it. So we're very, very busy, and we're much too busy to waste time with irrelevant documentation. Okay, so here we go. Interactive view, I&O.
First, you're going to go to your main menu. Once here, you're going to click into your interactive view / I's and O's. And then you're going to hit on the tab that states Adult ICU System Assessments. The first tab you'll see is your SBAR handoff. Seeing as we already did a mini presentation in regards to SBAR, we're just going to go ahead and skip that and get right to it, to monitor and parameters. So your monitor, when you come into your shift, first thing you're going to do is a head-to-toe assessment of your patients. So get in the habit of when you come into that room for the first time, you are going to go to the screen and make sure that your vital signs, that your heart rate, your blood pressure, all these things, that their alarms are on and audible, and that the values that set these alarms off are pertinent to your patient. So again, it's very patient specific. However, we do tend to have a generalization of values that we use here in the unit. For example, here you'll see that high oxygenation saturation alarm will be 100, low is 88, high heart rate is 150, low heart rate is 45, high respiratory rate is 30, low respiratory rate is 8. If your patient has an A-line, the A-line systolic high pressure will be 160 and low will be 90. Those same values apply if the patient is on a blood pressure cuff for the systolics, 160 and 90. And your high diastolic would be 90 and low diastolic would be 50.
Okay, so a word of caution. Appropriate alarms are essential to keeping our patients safe. Alarms are on and audible at all times. We assess this after any procedure, if the patient leaves the unit, before and after break, or if you disconnect the patient for any reason whatsoever. So again, the Philips monitors have default parameters that are set and safe for most of our patients. Occasionally, you need to adjust those parameters. The goal is to have the alarm sound when something is alarming and concerning. You don't want your alarms to sound nonstop. Alarms that are set too tight will lead to a phenomena called alarm fatigue. Alarms with no purpose are not only annoying, but they cause anxiety in our patients and give the perception that we're not paying attention to them. In SICU, we are collectively responsible for being aware of and attending to any alarm that you hear in the unit. Never ever ignore any alarm. When you are checking alarms, also please check that the patient is assigned correctly to the monitor. On admission, we will associate the monitor to the new patient. On discharge, we disassociate. So if we neglect to do that, the vital signs that you see on the monitor are actually migrating into the previous patient's chart, and you can imagine what a mess that's going to cause.
Next tab is patient safety. This is pretty much just a checkoff list of things that you should see and check right at the beginning of shift. So you need to make sure, again, your alarms are on and audible and set appropriately. Bed alarm is on, that you have an ambu bag in the bed in bedside, that the bed has brakes are on, both side rails are up, the call lights within the reach of the patient, that you are continuous supervision observer of the patient. If the patient has a feeding tube, you're going to go ahead and check that. IV sites need to be checked to make sure they are intact. Skin care, you will check that with the nurse who is actually leaving shift, and that your wall suction is on, connected, and working. Your fall risk interventions are basically, is the bed at the lowest point? Side rails are up. Brakes are on. Is everything near my patient that they don't need to get out of the bed? So all these fall risk interventions need to be in place, and once they are, you could go ahead and check as done.
So word of caution, assess first and then document. You never want to complete a checklist without first checking. You don't want to have an emergency and have to intubate a patient and there is no suction connected, or it's connected wrong, or there's no ambu at the bedside. You don't want a patient who has a mucus plug to not be able to call because they can't reach the call bell. You don't want a patient to fall because they can't reach the urinal or they're trying to get their cell phone. Please develop good SICU habits right from the get-go. We're very, very busy, but do not take shortcuts or make assumptions that might compromise patient safety.
Vital signs. So our patients here in the ICU, if your patient is doubled, that means you have two patients. You are going to chart their vitals every 2 hours. If you have a single patient for the day, the idea is that they are very critically ill and you need to be on top of their vital signs, so you will chart their vital signs every hour. If you see purple values, that means those values have yet to be verified in the system. Now we are very lucky that we have the Philips monitors, so they feed the actual vital signs into our EHR. However, we need to go ahead and confirm them. So I'll show you how to do that momentarily, but just letting you know, if you do see purple, that means they're not verified, and that means that the NPs and the physicians can't see those vitals. So you have to really be on top at those 2 hour marks and those hour marks to go ahead and verify your numbers so the NPs could see what's going on with your patient. And then go ahead and add any pertinent information, because the Philips monitor only gives you pretty much your heart rate, your O2 sat, and your blood pressure, but we need to add a few more things. For example, at 8 a.m., you need to go ahead and chart your temperature. This temperature is checked at 8, 12, and 4. You're going to say if it's oral, rectal, esophageal, intravascular, whatever it may be. So please be very mindful of where exactly it is that you're charting and how you received these values. Also, cardiac rhythm. Your heart rate might be 130, but is it 130 in AFib or is it 130 in sinus tach? So you have to go back and fill that cardiac rhythm out. Very important. Patient position. This is a great place to go ahead and chart that. We are supposed to turn our patients every 2 hours to help them be mobile and make sure that they don't have any pressure ulcers. So this is where you're going to document if that patient is right side lying or left side lying. So every 2 hours, what we should see in the documentation is that this goes from right to left, right to left. Cuff location, you only need to document once a shift. Just kind of say where the cuff is located, because as you all know, if the cuff is on the leg, it's going to give you a different value than when it's on the arm. If you do have an A-line, you have to make sure to get at least one cuff value to go ahead and make sure that it's correlating with your A-line. Once those numbers correlate, you do not need to continuously get a cuff blood pressure. You could go ahead by your A-line values. If you at any moment in time get your patient out of bed to chair, or your patient moves, or you disconnect the A-line for whatever reason, you have to go ahead and zero, which obviously we will teach you how to do, your A-line. So you would go ahead and correlate that with the cuff as well at that time. But for the most part, you only do it at 8 o'clock assessment. So as I said before, you'd go to your vitals. Here, temperature is oral, 36.1. Patient's in normal sinus rhythm. Patient is left side lying. The cuff is on the left arm. You also want to make sure to state what kind of oxygen therapy they are on. Nasal cannula, humidification, high flow, face mask. If it's intubated, then they're on the ventilator. Try to be as specific as possible when you're filling these things out. To find your hemodynamics, you need to go back to your main menu and click on Quick View, and then the tab that says Hemodynamic Measures. Here you'll see CVP, PA systolic, PA diastolic, mean pressures, cardiac output, cardiac index, SVO2. So all these things obviously are just patient specific, whatever applies.